Thanks, Anya. So on behalf of our team, I am delighted to introduce Dr. Adele Connor here today, who is joining us all the way from the sunny Gold Coast in Australia. Adele officially passed her PhD Viva during the summer, so we're particularly excited that we can use her new and well-deserved title. Adele worked with Associate Professor Antoinette Perry in UCD, and she researched ovarian tumors from around the body and examined how their differences affect a woman's response to drugs. So, to fully paint a picture of the tumor, she uses antibodies which help paint the tumor, thereby giving us a better understanding of that tumor. So, we're very excited that Adele is going to tell us more about this today and what she discovered during her PhD. So, without further ado, I will pass this on to Adele.
Thank you so much, Serena. So I'll just quickly, I'll share screen, make sure everyone can see the slides. So can you see that, Serena? That's all looks okay?
It's coming up now for us.
Yeah. Okay, brilliant. So yeah, thank you so much for that introduction, Serena. So yeah, as Serena said, my name is Dr. Adele Connor, and that is extremely exciting because that was the first time I've been able to use my full title since passing my PhD Viva back in June. So as Serena said, my research focused on ovarian cancer, which is why my talk today is called Painting a Picture of Ovarian Cancer. So I just want to begin with kind of an overview of what I'm going to discuss over the next half an hour or so. So I will begin with an introduction to what the whole project was about. I'll then talk about some of the results that I got over the last 4 years. I'll also discuss how these results could potentially impact patients or what the impact could be for patients from these results. I also then want to talk about public and patient involvement, or PPI, as this was a huge part of my project and something I feel really passionately about. So I want to talk about how I got involved there and how that worked at incorporating the patient voice into a lab-based research project. And lastly, then, I just want to touch on some of the World Gynecologic Oncology Day or World Go Day events that have happened for World Go Day, which has happened on the September 20th, and just some of the events that have happened around Ireland for that. So straight into it then. So just an introduction to the project. So as I said, my research focused on ovarian cancer, but specifically looking at a type of ovarian cancer known as high-grade serous ovarian cancer. And one of the big problems with this cancer type is the fact that the symptoms are so vague. So often these symptoms are referred to by the BEAT acronym, where B is for bloating that is persistent, E is for eating less and feeling fuller, A is for abdominal pain, and T is for toilet changes. But I think it is very clear to anyone who menstruates that those symptoms are extremely vague and can be very difficult to spot. And unfortunately, it's because of that in fact, 75% of patients will actually present with advanced stage disease that is already spread around the body. And currently, there is a knowledge gap surrounding our understanding of how these tumours behave and respond therapeutically within individuals. The treatment for this type of cancer has remained relatively static over the last number of years, so primarily focused on surgery in combination with chemotherapy. And although 80% of patients will initially respond to this therapy, this can be short-lived and resistance can ensue for a number of patients, which is why we desperately need new treatment options for these patients. So with all of that in mind, the research questions I had for my project were, okay, well, what are the differences between these tumours that have spread around the body? How do these differences affect treatment response for that patient? And the reason why I did this was I was hoping that this could eventually lead to a personalized, tailored treatment plan for patients. So how exactly did I approach trying to look at all of that? To understand that, we've got a paint by numbers picture here. So this, we know that there's a picture hidden inside here somewhere, but we're not quite sure exactly what the picture is, not at least until we've added our colors or our paints. So once we've added colors or paints, we can now very clearly see that this is a picture of a castle. So that is similar to how we can work with tumours in the lab. So tumours that have been very kindly donated from patients undergoing surgery can be taken back to the lab, and we can dissect these tumours into thin slices of tissue and place those onto a glass slide. So at this stage now, similar to our painting, we know that this is just a piece of tumour. We have no idea what's going on inside, not at least until we've added our colours or our paints. And the paints that we work with in the lab are known as antibodies. And once we've added on these antibodies, we can then look at this tumour under the microscope, and now we have a picture of what's going on inside that tumour. Now, although we are getting a bit more information and we can see what's going on inside, we are still missing a little bit of information. So if we go back to our picture of the castle there, this is just a flat 2D image. We have no idea maybe how far back that castle stretches or if there's a garden surrounding that castle. To really understand that, we would need a 3D model of that castle. So similar to the one that we have here. We can then add our colours and our paints. And now you can very clearly see that we have a lot more information about this castle using a 3D model compared to just our flat 2D picture. So that was similar to how I approached working with tumours in the lab. So similar again, tumours that have been very kindly donated from a patient undergoing surgery can be taken back to the lab. And now I can dissect these tumours into these little 3D mini tumours. So instead of slicing them into individual thin slices, I'm keeping them as intact 3D pieces of tissue. And again, I need to add on my antibodies or my colours or paints. And I can now look down the microscope at this tumour, and I'm able to get a lot more information about this tumour compared to if I was just looking at one physical slice. So that was the approach that I took for my project. So I'll just talk through maybe some of the results that I got. So the first kind of objective I really needed to achieve to kind of really get this protocol up and running was that I needed to develop a protocol for actually processing these mini tumours. I then needed to develop a protocol for the 3D painting of mini tumours because majority of the time these protocols are used for those 2D pieces of tissue, but I was looking at them as these 3D mini tumours. And then thirdly, I had to develop a protocol for then the 3D counting of individual cells. So although I needed to paint the tumours, I then needed to be able to count and really understand and quantify what was going on inside. So for this first objective, I was lucky enough to be able to go to the University of Leicester to Professor Katrin Pritchard's lab, whose team had already developed protocols for processing these mini tumours. So I was able to go to Leicester, learn that protocol, and then bring that back to UCD because that wasn't being done in UCD at the time. So now I'll just talk through kind of the objective 2 and 3 and the results that I got there. So firstly, to develop the protocol for the 3D painting of the mini tumours. I'll just get my little pointer up so we know what I'm looking at. So what we're seeing here, we've got 3 different pictures here. We've got a picture A, B, and C. And these are just pictures from the same little mini tumour from the one patient, but it's just looking at different kind of heights. So if we look down at the little schematic here, we've got this little 3D mini tumour, and picture A is looking at a slice kind of around this height of the tumour. In picture B, we're going a little bit further up, and then in picture C, we're going a little bit further up again. So instead of me getting one kind of physical slice of the tissue or looking at a 2D piece of tissue, I am now able to keep these mini tumours intact and kind of get the paint throughout the whole piece of tissue and then look at what we call optical slices instead of physical slices. So this was kind of a big success right at the start of the project. We weren't sure if this was going to work, and most of these protocols have been developed for working with these kind of thinner pieces of tissue. So what this told me is that I am able to paint these tumours and it will paint through the full volume. So that was a great result. Secondly, then, what you can see kind of here in very clearly in image B, you can see that there are kind of these little circles, these little individual blue circles, and they are just individual cells. So what this also told me is that not only am I able to paint throughout the full volume of the mini tumour, I'm also able to identify individual cells. So that was the real goal, to really be able to achieve a resolution or a really good definition that I could see these individual cells. So The outcome here is that individual cells were identifiable using this 3D painting protocol for these mini tumors. So this gave me a lot of information. So next, once I was able to kind of paint the tumors, I then needed to count the individual cells. So again, I had to develop a protocol for this. So just to kind of give you one example, this is just an original image. So this is one of the same images I showed you in the last slide, but now it's just in black and white, because when I've input these pictures into the computer software, they just go into black and white instead of working with color. So what you can see again, we can clearly see we've got our individual little cells here, and I can visibly see those, but I now need to know, can the computer software see those and kind of count them? So to do this, I have to apply numerous different filters. So this is similar to if you were to take a picture of yourself and you want to upload that onto Instagram, you might test out a few different features and filters to try and enhance your features to make yourself look as best as you possibly can. So one filter might not work well for you, whereas the other one might work better. So that's similar to how I work with these pictures of the tumors on the computer software. So I tried filter 1, filter 2, and filter 3. And for my sample type, it was actually filter 3 that worked the best. And I'll tell you why that was now. So again, this picture that I'm highlighting here is just the same one that we've got above, but now all these different colors is just the computer software trying to recognize and identify individual cells. So if we look at this little kind of red box, this is just a zoom to see it a little bit better. So the computer software is telling me that this is one cell, but I can kind of visually see that in fact there's 3 different cells here. So this is the image without any filters applied. But then when I applied my filters, again, we're looking at the same image now, just in this red box, the same cells are now being segmented, or there's more definition, and we can see that there are in fact 3 cells here rather than 1. So that's what told me that appropriate image filters are needed to try and improve the cellular definition, so that I can not only obviously I've painted through the tumors, but now I can quantify and count the number of cells that are present. So again, that was kind of another success of the project. But what does any of that mean? So obviously I can now paint these mini tumors, I can count the individual cells, but what does the counting of these cells actually tell me about the tumors? So just to give kind of a basic example here, we have mini tumor 1 on the left and mini tumor 2 on the right. And this is from the same tumor, from the same patient. So I think what is immediately obvious is that there's a lot more blue on the left compared to on the right. And the blue is just our blue paint that stains kind of all the different cells, whereas the green and the red are staining specifically cancer cells. So we can see that in fact in the mini tumor here on the right, there's a lot more cancer cells compared to the one on the left. And that's just telling me that by counting these individual cells, it's really revealing the heterogeneity between the mini tumors. So just kind of on a basic level, we can see how many normal cells versus how many cancer cells. But we can look at that and apply that and add different paints to look at different type of cells. So that's the ultimate goal. So I hope you're still following along. If not, you can ask me any questions at the end. But what does any of that mean for patients, or what is the impact that these results could have for patients? So firstly, if we can paint these tumors and we can count the cells and understand what's going on, one of the things we can look at is tumor activity. So we can look to see if there's maybe something switched on or switched off based on the type and number of cells that are present. And what this is going to tell us is that it will inform maybe what drugs that we could treat with that could target these specific activities. Another really important aspect that we can look at is the tumor environment. So if we picture back to our castle analogy, so we have our castle here surrounded by lots and lots of soldiers. This would be similar to if we had a tumor that was surrounded by lots and lots of immune cells. So that's what we'd call a hot tumor. Alternatively, if we had a castle that wasn't surrounded by too many soldiers, this would be similar to a tumor that didn't have very many immune cells around it. And that's what's known as a cold tumor. And we know that hot tumors, in fact, respond better to treatment. So if we can count the number of immune cells and maybe even the type of immune cells, that can help to inform maybe what treatment could be used. We can also look at the tumor drug response. So we can treat these mini tumors with different types of therapy. So we can look at chemotherapy, PARP inhibitors, immunotherapies, just as a few examples. And then by counting the cells that maybe responded or didn't respond, it helps us to identify the drugs that worked. So we can make sure that we are giving the effective treatment to patients, but also importantly, we can identify drugs that don't, so that we can spare patients the pains of ineffective treatment. And ultimately then, what we can do is we can look at the tumor activity, the tumor environment, and the tumor drug response, and we can compare all these three things between those multiple tumors within that one patient to then hopefully develop a personalized treatment plan or approach for that patient. So the way that this would work is that when the patient has surgery to remove tumors, then those tumors can then be brought back to the lab and dissected into these little mini tumors. They're grown in the lab for around 48 hours. We can then treat them with different combinations of therapy. We can add on our antibodies or our paints so we can see what's going on inside. We can use the microscope to look at the tumors. We can analyze our results, and then those results can hopefully be reported back to the clinician, whereby we can then begin to develop a personalized treatment approach for the individual patient. So just as a summary and kind of where the project is at now, or where the research is at, I've managed to establish a protocol for the dissection of these mini tumours. So I was able to learn that technique in Leicester and bring that over in UCD and have that set up in UCD. I was able to establish a protocol for the 3D painting of mini tumours because, as I said, most of these protocols are done on those 2D flat pieces of tissue. I've also established a protocol for the 3D counting of these mini tumours. So now I'm able to also see inside, but also quantify or count what's going on inside the tumour. And lastly, I'm currently working on a paper that I can hopefully publish this work so that it can be continued to develop further, because this is kind of the starting stages of getting this protocol up and running. But now work needs to continue on it. So hopefully if I can publish this, other people can continue to work and develop it. So we can get closer to developing those personalized treatment plans for patients. I next just want to talk about involving patients in lab-based research. It's something that I've extremely passionate about, and it's one of my favorite, I think, things of the whole PhD, and it was something I hadn't really heard of before starting the PhD, and I just think it's a really important thing for researchers to incorporate the patient voice. So I just want to kind of maybe talk through how I got involved with PPI and how you could approach it going forward. So I first got involved with public and patient involvement, or PPI, when I was applying for a PhD scholarship to the Irish Cancer Society. And on this application, there was a full section about how you plan to incorporate the patient voice or involve patients in the research. And to be completely honest, I hadn't a clue where to start. As I said, I'd heard of PPI, but I had never done it. So I decided to reach out to Ovacare, which is an ovarian cancer community in Ireland, which is where I met the lovely Dr. Sharon O'Toole. And Sharon invited me to speak at Ovacare's Coffee and Chat morning, whereas I was able to present my plan for the research project and also my plan for incorporating the patient voice. And I was able to get feedback on this from the women that attended there, which was invaluable. And I was also able to kind of check to see if anyone was interested in getting involved with the project if it was funded. So lucky enough, and because I'm sat here today, the project was funded, and I was lucky enough that there were two women there that day that were interested in getting involved. So from here, we were able to establish a patient advisory committee. So this committee, we had our first meeting over Zoom, as it was still kind of in COVID times. And this was really kind of an introductory meeting where I was able to introduce myself and the project in a little bit more detail. And the two patients were able to introduce themselves to me in a bit more detail and talk to me about their story. And it's also at this point that we developed our terms of reference documents. So these are documents that just outlined what it means to be as part of this patient advisory committee. So maybe what time commitments might be involved and what meetings might come up over the next few years. And I think it was really important establish these together, so that we were all on the same page. And importantly, it also outlined that this is completely voluntary, that if at any point someone didn't want to be involved, that was perfectly fine. And if they wanted to dip in and out, that was absolutely fine as well. So I think it's important to kind of establish this at the start so everyone is on the same page and knows what to expect. So I think the point when PPI really kind of became very important in my project was kind of right at the start, because one of the questions I had for my project was maybe what treatments should I be testing or looking at on these mini tumours. So to answer this, I could have looked at clinical trials, you can speak to clinicians and you can consult the literature, but you can also speak to the patients themselves, who are the people that have actually been on some of these drugs. So that's exactly what I did. I turned to my committee members and we decided to have our first in-person meeting. So this began with an initial meet and greet because the committee had now grown from 2 members to 5 and not everybody knew each other. So we had an initial meet and greet over teas, coffee and biscuits so everyone could kind of get to know each other before we got into the discussion. We then had a lab tour, which I think everyone enjoyed. I was able to kind of show them around a cancer research lab and talk through what it means to be a cancer researcher like on a day-to-day basis. And they were able to ask loads of questions, which I think they enjoyed. And then we had a group discussion. So this began with me giving a very short 5-minute presentation about what the project was about. And I finished this presentation with this slide. So I asked the group, would you be able to discuss the treatment that you're on? How was your treatment plan created? Can you discuss your side effects? And what's your perspective of your current treatment? And I think that by putting up these really specific questions, this really helped to guide the discussion and made sure that we got the most out of the time that we had together. And the outcome of this is that I was able to develop a revised patient-informed experimental plan. So I knew I was interested in treating with PARP inhibitors, and I knew that there was a range available, but I didn't know, should I be testing one over the other, or did that really matter? Naively, I also assumed that as this was a more targeted therapy, and that there would be less side effects. But having spoken to patients, I've learned that in fact this is not the case, and they actually have quite a lot of side effects. And from further research, then I found out that these have varying toxicities. So in fact, testing a range does provide more options for patients. So the decision was made to include a range of PARP inhibitors as a direct result of speaking to patients. And we were then able to publish this work in the Journal of Research Involvement and Engagement, and the 5 patient partners that were there that day are authors on that paper. So as a result of this kind of successful incorporation of the patient voice into a lab-based research project, myself and 3 other PhD students in the group decided we wanted to broaden patient involvement in ovarian cancer research. So we applied together with patient co-applicants and were awarded the Irish Cancer Society PPI funding back in 2022. And this had a focus on equality, diversity and inclusion. So we decided to reach out to and engage with the Bangladeshi community kind of as a pilot scheme. And the reason we did this was because we were in contact with Dr. Arman Rahman in our group, who has a wealth of experience at engaging minority communities in science and cancer research through his Invisible Spectrum events. So we had our kickoff meeting in March 2023, the researchers and also the patient co-applicants, to kind of discuss our next steps and how we were going to implement our project. So the first thing that we decided to do was to design a video to try and encourage involvement. So we released this video in both English and in Bengali. And this video was it was an introduction to what PPI means. It kind of outlined what research was going on in the group, the different ovarian cancer research projects. It highlighted kind of how the patient voice can impact your research project, and it just let people know how to get involved if they were interested. And this was very successful. We had over 470 views on our videos, but mostly the big success is that it resulted in us being able to engage with 17 new members. So these are 17 new women that we were able to engage with and form relationships with that we can continue to incorporate into the research going forward, which is absolutely fantastic. And 3 of these members were actually women from the Bangladeshi community, which was brilliant. And we held our first workshop on the 8th of September back in 2023, and this followed the same course as I described in the previous the workshop that I did at the start, and we had an initial meet and greet, there was a lab tour, and then we had our discussion. And we also finished the day with a lunch, which I think was really lovely and really important, and I think everyone really enjoyed, because it kind of gave everyone an opportunity to talk and engage with each other kind of outside the confines of researcher and patient. So I think that was a really nice way to end the day. We then had our second workshop in April, and then we had our conclusion workshop in January of this year. And at this concluding workshop, we were able to invite other ovarian cancer researchers from other universities across Ireland and the patients that we had met. And the idea really being that we didn't want kind of the PPI to end with this project ending or this funding ending. So we wanted to make sure that everyone who was interested in incorporating the patient voice, that they could kind of get in contact with each other and it could continue to go forward, not just in UCD, but across Ireland. So the impact that this PPI had on our 4 different projects within UCD. As I said, this is my project here, which I've already discussed, but there were 3 other projects. So Claire Hughes's project was looking at CBD, and initially Claire was looking at CBD, looking at the anti-cancer effects of CBD to be tested alone, but having spoken to the patients, she learned that she should probably also look at CBD in combination with chemotherapy, because potentially there's anti-cancer effects of CBD, but also it could potentially help to alleviate some of the negative side effects associated with chemotherapy. So that came about as a direct result of speaking to patients. Asia Jordan's project then, she's looking at developing a diagnostic test for ovarian cancer. And one of the big things that came out of her discussion was that she needs to hopefully ensure that this diagnostic test is better than CA125, which is the only test available at the minute. And it's not very specific and it's not a screening tool. And I think the patients were saying that a screening test is going to be the best method for fast tracking ovarian cancer diagnosis. So that is something that Asia was able to incorporate in to try and make sure that the diagnostic test she was developing could potentially be used as a screening tool. And lastly, then Leah Schaefer, this project is looking at a new biomarker for treatment resistance. So what came out of the discussion for Leah's project is that the reliability of this marker obviously needs to be guaranteed, that it needs to be robust, which is very important, but also something to kind of just think about kind of in parallel is that it's one thing being able to know if potentially someone might become treatment resistant, but that's only helpful insofar as if there is the availability of alternative treatments. So that's something that could be looked at kind of in parallel and something Emily can think about incorporating into a project, or it could potentially in projects down the line. So we have had incredible impact of PPI or the patient voice in our projects. And some of the outcomes from this is that we've been able to publish numerous different articles about this. And we also have one work in progress article at the minute as well that we're trying to work on. And I think this was really important to us because when we were starting out doing patient involvement, we felt that there wasn't a huge amount of information out there for how to begin or how to get started. We didn't really know what we were doing at the start. We were kind of learning alongside the patients that we were inviting as well, because there was a huge amount of information for how to incorporate the patient voice maybe into healthcare research, but not so much into a lab-based translational research projects like this. So we're hoping that by publishing our work and kind of saying how we have done it or how we've incorporated the patient voice, that this could maybe provide a toolkit for other people so that other researchers might consider involving the patients in their research, because we believe that there's a lot of benefits of PPI for researchers. So just to name a few, there is a re-energized motivation for your work with the reminder of why we do this research. The research is focused on the unmet needs of patients and on the true unmet needs. There's also a greater understanding of the lived experience, which can only stand to make you a better researcher, and also questions that you may never have considered or thought of before can now be incorporated into the research project. So finally, then, that brings me to just want to talk about some of the events that have happened for World Gynecologic Oncology Day or World Go Day. So happens on the 20th of September every year, just a few days ago. So this is really being led by INGO, which is the Irish Network for Gynecologic Oncology, and spearheaded by Dr. Sharon O'Toole. So some of the outputs that they have achieved from this is that they've released this gynecological cancer symptoms leaflet, and it's just really trying to raise awareness and get women speaking about the fact that there is in fact 5 gynae cancers, which I don't think maybe everyone's aware of, and it's just really highlighting the symptoms. So it's something that they can be kind of looking at and keeping track of, and it's just empowering women to be able to know kind of their bodies and understand the symptoms, and to be able to maybe use that if they need to go and talk to their doctor. Every year as well, there's usually a fantastic talk held by incredible speakers. So there was a gynecological cancer information event held this year, I think in St. Stephen's Green, which again, just a wealth of information available there at those talks. So something to consider if you wanted to think about going next year. There's also the Dip or Dance campaign, which I have been lucky enough to be involved in over the last number of years. And again, just trying to really raise awareness about the fact that there is the 5 gynae cancers, and just kind of get women talking about gynae cancers. I think it's not always something people want to kind of talk about, or it's kind of shied away from. So it's really just trying to open up the conversation. And I looked on the World Go Day website, and in fact, I think there was over 50 Irish events happened this year, which, as I said, huge thanks to Ingo and Dr. Sharon O'Toole for organising all of those. And you can have a look there and see if there was a swim or a dance event near you, and it'd be something you can think of looking at next year. Or in fact, if there's nothing near you, you can maybe look at organising an event yourself. You can get in contact with Ingo or Sharon, and they'll be able to send you out swim hats, and you can organise your own event. And lastly, then, I just want to highlight the This Is Go website. It's an incredible resource developed here in Ireland by researchers, clinicians, and patients, and it's just a wealth of information for all things gynae cancer. So if you want to get any more information, or you're worried about any symptoms, that is absolutely the place to go. And I think on the website at the minute as well, there is a webinar from the gynae on the World Go Day event from last year. So if you missed this year's event or the talk, you can go on to the website there and take a look at the one from last year. So that is it for me. Thank you so much for listening, for giving me your time. I'm happy to take any questions if there's any. Thank you so much.
Thanks so much, Adele. A fantastic talk, just a huge amount of work crammed into a 35-minute presentation. So well done. There's actually a lot of questions I have. Sorry to say. But I guess my question ties in with someone else's question as well. But just to get, because obviously if we look at it overall, doing a PhD is a huge commitment. But to the people in the audience who are thinking about doing it, what was your motivation to do this to research this specific topic, and why did you choose to do it in UCD and with Antoinette Perry?
So I think specifically the topic that I was looking at, like ovarian cancer, I actually was working with Antoinette as a research assistant working on prostate cancer, and that's how I got in there, and just kind of loved kind of the research environment. I had been out of research for a while. I had traveled for a bit, and I'd come back, and I was really interested in the translational aspect of it. So there's obviously basic science that you can look at, but what I really liked was, okay, well, why are we doing this? And I could really see that with Antoinette's work. Her prostate cancer test the idea was trying to find a diagnostic test for prostate cancer, and I could see the real impact for patients, or the real world impact of that. So that's really my motivation, I think, for working with Antoinette. And from there, when I was working as a research assistant, there was another PhD student in the group who was researching ovarian cancer, Romina Silva. And honestly, like, I hadn't really heard much about ovarian cancer, and it kind of shocked me a bit. Like, as a woman, you think, and even it wasn't until I was really getting into the gynae space that I didn't realize that there's actually 5 different gynae cancers. And then I was at a conference as well, and I think they showed the amount of research papers that are released maybe on breast cancer in comparison to ovarian, and it was just drastic. And that really motivated me to be, okay, well, this is not being discussed, it's not being researched, so that's something that I'd really like to get involved in. So yeah, it's really kind of, I think, the translational aspect of Antoinette's work, and then the ovarian, just I think from the point of view of women's health, and really wanting to try and get more out there on women's health. So yeah.
And I guess a huge part of your project was very much centered on strong PPI work. So that brings us, we have a lot of questions about PPI here. So the first one is, when a person is faced with cancer that is not responding to anti-cancer drugs, how can we better inform them so they can meaningfully contribute to decisions around their own health and alternative treatment choices? Could translational researchers or clinicians play a part in providing accessible information and improving the health literacy of these groups?
Oh, absolutely. I think, yeah. So I think that's probably a responsibility really of researchers and maybe medics as well, is that yeah, we obviously it can get the scientific jargon can get difficult, and even between us, like as I said, some of the other girls in the group, like some of their projects, like if I wasn't working on this specific thing, it's even difficult for me to understand. So I can't even begin to understand if you didn't maybe have a scientific background, you're trying to get all this information from your doctor or whoever it is. So I think absolutely, I think trying to empower people with information that they can understand and yeah, that they can go forward then. And I think it's only by working together, researchers working together, and the patients, and everyone having the confidence and respect for each other, for someone to say, well, actually, no, I don't understand what that means. Could you explain that a different way? And for us to be like, yeah, absolutely, and trying our best to communicate things a little bit better, trying to remove the scientific jargon. We're all guilty of it, but I think that's absolutely something that, yeah, I think patients and researchers can work together to try and empower and give people a bit more information.
There's also this kind of level of intimidation that we're trying to take away between clinicians and researchers and the patients as well, is to make everyone feel as if they won't feel stupid by asking a very simple question, what they would perceive to be very, very simple, but actually it's fundamental to them understanding their disease.
Absolutely. And I don't think there is kind of any stupid questions. And it can feel like that a bit, I think, when you're going into a room with maybe people that might have doctor in their title or professor and stuff like that. But
Exactly.
it is at the end, and I have seen before, I think I know I was very excited to be able to use my doctor title there to first time. But I think it is important to remember we're all just people, we're all just humans. And I've seen trying to maybe remove those titles when if you're doing a PPI event so people maybe feel a little less intimidated, or I've also heard of people having kind of an icebreaker where it's some type of activity that no one can do, and it kind of just levels the playing field. That's
Mm-hmm.
like no one's good at this thing before, and everyone feels a bit more comfortable. But I also think that by when we did our lunches after the PPI events, that was really where we all just chatted as just. It wasn't even, we weren't even talking about research or science or anything like that. It was just chatting to each other as people and as friends. And it wasn't research or patient. It was just we were all out for a nice lunch and getting to know each other. And some of the women that I've met kind of right at the start of my project, like I'm still friends with them now, and it's a lovely relationship to have. You just become friends and kind of colleagues, and I think that's important that everyone feels comfortable. And I think a huge thing is respect, that everyone is listened to. There is no stupid ideas, there is no stupid questions, and it's all just discussed. And if everyone feels like they'll be listened to, I think that's really important.
So that actually ties in very nicely to the next question. Did you find any unique benefits from your efforts to diversify your panel? Did everyone work well together? And there's a kind of a part B to that question as well. I'll let
Yes, so I
you.
think there absolutely was, and I think maybe we obviously just engaged with the Bangladeshi community, as I said, as kind of a pilot scheme. We did initially think about trying to reach out to multiple different groups, but I think what stopped us there was maybe the language barrier. We wanted to make sure that we were doing it properly and we got translators and everything in, so everyone felt like they were able to communicate. And I think, yeah, one of the things that came up is it could be the same in Ireland as well, but I think specifically looking at gynae, it can be very difficult to kind of maybe talk about or to trying to bring up. But I think having a room of people where everyone felt comfortable to talk about it, you could see people were starting to open up and people felt a lot more comfortable. So I think that was fantastic. And just people getting different perspectives from different cultures was, yeah, it was brilliant.
Question is, did you try to engage with any people with ovaries who do not identify as women as part of the PPI?
We approached that. I think there was another funding that we had considered doing as well. At the start, so I can't remember the group now that I know we reached out to, and I think one of the things we tried to do was maybe to have kind of maybe gender neutral words, and trying to think about our language and what we were doing and what we were kind of promoting and some of the videos and stuff that we released. But it wasn't something we went down on. So it is
Mm-hmm.
something think another aspect that you could kind of maybe look at and incorporate in. I I think the fear that we had at the start, we had lots of ideas. We wanted to diversify and engage with as many groups as possible. I think the worry that we had was that if we kind of tried to do too much, we wouldn't do any of it well. So we wanted to maybe just focus on, as I said, because Araman had experience in engaging the Bangladeshi community. That's why we went there first. But I think with that now we've learned how to kind of maybe do that. There was a bit of success there. And I think it's about kind of continuing to add on and making sure that, okay, you maybe go into the next group and making sure that everyone is feeling like they're incorporated, but you're not just maybe doing it half-heartedly if you try to do too much at once.
I agree. I think the intention is always there, but to focus on one specific part of it and do it really well, it speaks volumes and is much better than doing lots of maybe other bits. So
Yeah, exactly.
the other question about PPI here was, and you kind of touched on this already, but what would you recommend to other researchers who want to implement PPI in their work?
I think the biggest thing I think I can say is just get started. I think that was where we started. There was lots of chat at the start, and we were like, "Oh, how do we do this properly? We don't want that. Maybe that's not it, or is that the right way, or is this the right way to?" And we maybe tried to overcomplicate it at the start, and we kind of kept getting confused because, as I said, we were looking for information and finding it more for healthcare research, but it didn't really apply to what we were doing in the lab, which can be a bit more technical. And it kind of maybe can put you off a bit by being like, oh, that's complicated or I don't know how to do it. But I think just make the first move, like just maybe just start and admit from the very start that you're learning just as much as maybe some of the patient groups or people who have maybe never done it before. Like you're all learning together. And I think that does maybe level the playing field as well to say, like, I'm not sure, is this the right way to do this? Is this how you like to have meetings, or is this something that would work better for you? And kind of learn as you go and you learn together, and that's going to help you form relationships and form bonds. But I think the biggest thing is just start, just maybe reach out to one of the charities or one of the cancer groups and just make a start, and you can go from there. If you wait until you know exactly it's going to be perfect, it's going to be this, I just don't think you'll ever start. So I think just make the start is the best thing.
Sometimes you might miss the opportunity as well if you have, waiting for the perfect plan to formulate. Okay, so then the next question is, and again, you've touched on this, what is your biggest learning and takeaway that you got from working with PPI?
Biggest learning and takeaway. Oh God, there's a good. It was probably my favorite part. I think I've said this before of the whole project. So I can't think of like one one learning. I think it was, yeah, I think as I said, maybe I overcomplicated it in my head to begin with, and I didn't want to waste people's time. But it was kind of maybe just getting started and to be honest and say, I'm not sure exactly what I'm doing here, but we'll figure this out together. And learning that they didn't care. They were just like, great, that sounds good to me. And
Mm.
they didn't feel like I was going to waste their time, which I was just really conscious of because I was aware that people were giving up their time. They were there to listen to what I was trying to talk about, and I wanted to make sure I was making the most of their time. But I think, yeah, just learning that people were just happy to be there, and if people wanted to be there, they would be there. So yeah, just being honest, I think is the biggest thing.
You kind of feel like as if you have to know everything first before you say to your patients, okay, this is what we're going to do. But that kind of level of transparency just breaks down barriers too. So absolutely. Yeah, I
Yeah.
totally agree. And that ties in very nicely to the last question, which what was your favorite part of the project? So Adele, I just want to say thanks so much to, giving us this talk, explaining more about your project. And a huge congratulations again on your fantastic achievement, the fact that you have your PhD now and you're living the life, living life at large in Australia. But yeah, if there's any questions from the audience, feel free to reach out to myself. I'll be I'll be happy to pass them along to Adele. But yeah, thanks again, Adele, and thanks everyone for joining.
Thank you so much. Yeah, thank you, Serena, for asking me to do it and for hosting, and thank you everybody. Yeah, for listening in and for all the questions. It was nice to have the discussion. Thank you.
Absolutely. We'll chat to you soon, Adele. Thanks very much.
Thank you.